Hospital workers. What happens there that's hidden that the hospitals do not want us knowing? In the ICU, you spend a lot of time keeping corpses alive until their family comes around or their body gives out. Oh, Jesus ain't ready for her yet. Yes, Jesus is ready for her. We're just actively delaying it. Next story. That patient families will do anything to keep the patient alive for their own comfort instead of abiding by the doctor's order. For example, feeding an intubated patient a hamburger because he's hungry, when they are already being tube-fed and ordered not to interfere with the vent or track. This has resulted in many patient deaths than you think. Next story. Hospital lab worker here. Not particularly scandalous, but most people don't realize their lab tests are just very accurate guesses and have an error range. When we say X is your 10 grams over liters, we might actually mean it's 10 grams to liters plus 10 to 20%. I see too many people get extremely worked up about small fluctuations in blood test values that aren't actually in excess of the reference change value, and so technically aren't genuinely different from the previous value. Next story. I got a fast bleep, i.e. drop everything you're doing and attend to this emergency, please. One night, to a side room on the ward to find no patient in the bed. Was just about to leave the room and go back out to the nurse's station, where there had been a bit of a hubbub when I dashed past the first time, when something caught my eye. Looked up to see a face with wide, slightly wild, psych eyes peering down at me from a gap in the ceiling tiles. She was a lady waiting for a bed in the psych hospital who'd clearly thought the ceiling was the best place to hide from the people trying to poison her. Honestly, can't think of another occasion that I've been quite so terrified. Worst thing was that I had to walk, back out underneath her to get help from the nurses and security to get her down. Next story. It's not uncommon for families to abandon elderly members at the hospital. They will straight up ghost, or at least will be polite enough to say they won't give any assistance to us in placing them in a nursing home. So adult protective services will get involved and make them a ward of the state. This process can take weeks to months, so these abandoned people just live in the hospital and take up the resources that could be used treating sick people. There are also many families that keep elderly members in unsafe living conditions, so they can continue to take their social security checks for personal use. Next story. Not hidden per se, but for the love of all that is holy, if you insist on bringing your kid into the hospital, do not let them crawl or play on the floor. The amount of literal blood, urine, poop, and vomit that has been on it, and hastily, not thoroughly cleaned up is, well, a lot. The hospital, especially the floors, is not a clean environment. Added to that, think of all the rooms, the nurses, the doctors, housekeeping staff, etc. that have walked into the rooms that have COVID or norovirus or group A strep. We walked into those rooms and those same shoes walked into other rooms. Too long didn't read? Hospital floors are disgusting as F. Next story. Not really hidden and kinda minder, but I'll say it anyways. I deliver food to patients, and it's not hard to tell when someone is on their way out. Could be simply not being hungry, or could be the inability to eat. Had one patient who hadn't eaten anything off their tray for 3 days straight. The last time I delivered to them, they smiled and gave me a wink. Next day, they were gone. It's rough seeing these things happen in real time. I'm a grown man who doesn't cry often, but it always leaves me feeling extra empty, picking up the untouched trays and replacing them with another tray that I know will stay untouched as well. Next story. There is an army of pharmacists in the basement that approve every medication entered by every doctor, frequently catching errors that need a change in therapy. Patient on dialysis can't have X med due to toxicity risk. Why is this patient on 2 nitrate-containing meds? This patient is 90, and her QTC is already 500, so maybe let's reconsider the Levaquin. Is that how you say that? This guy just got that antibiotic in surgery 2 hours ago, so I'll reschedule it to tomorrow. Why is this patient not on blood thinners when they are at high risk for a clotting event? Another doctor already ordered potassium repletion for this patient, so do you want me to delete your orders as a duplicate? You forgot to order a thyroid test before starting amiodarone. This person's kidney function has stabilized, so we can increase their antibiotic dose again. Can I change this pantoprazole order to lansoprazole because you can't crush pantoprazole and the patient has a G-tube? Please enter an updated weight for the tiny NICU baby. Can I redose all of their weight-based medications? Did you really mean to order 1030 units of insulin for this patient, or did you want them all to get it at 1030, etc.? Could have really used a period somewhere in there. Next story. When nurses/MDs, etc. are laughing and joking with each other, it is a coping mechanism. We aren't trying to be rude, we are compartmentalizing the trauma that we see all day, every day. If we don't lighten the load, we would cry all day and never come back to work. It's literally the only way to watch a baby die and then deal with screaming Karen next door without punching them in the face. Next story. The lab. The many labs inside a hospital are what you don't know about. A hospital without a lab is just a bunch of people guessing. A hospital without a lab is a collection of doctors' offices. Think about that for a moment. The lab is not where they draw your blood. The lab is where that blood is sent to have various tests. Each colored tube does something very specific. Those tubes need to be filled to a certain amount. They need to be drawn in a certain order to keep contamination from causing issues. Sometimes they even need to be drawn from certain places. The lab takes your blood, sweat, urine, fluid drainage from cysts, wounds around your heart, lungs, liver, brain, etc., nose swab, cheek swab, feces, tumors, removed organs and appendages, growth, and many other unwanted parts and fluids. The lab knows that you eat too much sugar, you lie about that cigarette you enjoy every day, and that you need to stop taking so many over-the-counter pain relievers. The lab knows when you have chemo. The lab watches your platelet count go down. The lab knows about the deletion of that one gene or the doubling up of another. The lab ran your PCR COVID test and saw you become a statistic. Then they asked a blood donor program to hit you up for COVID convalescent plasma, so that might save a life. The lab monitored your time on the heart-lung machine. The lab knew when you needed platelets and blood. The lab saw your lupus diagnosis first. The lab was nearly as upset as you were about it. The lab was overjoyed when they got the news to pass along to your doctor that the stem cells came in for your bone marrow replacement. Nurses and doctors see you face to face, but the lab knows you from your insides. The lab is faceless to almost everyone in the hospital, even other staff, which is a shame because the lab is cheering you on in your recovery. Was this like an ad for the lab? If so, well done. Let's give it up for the people in the lab, man. Next story. I haven't seen it on here yet, may have missed it, but I'll add. You, as a patient, have every right to refuse any test or treatment or even leave at any time, for any reason, unless a harm to self or others. That's different, at least in the US. Added bonus you should know, leaving against medical advice does not mean insurance will not pay for the care you've received. Your insurance will still be billed the same as anyone else who stayed the whole time till discharge. But if you leave with an IV in your arm, we will call the police to find you and bring you back to remove it because of drug abuse. Next story. In the US, insurance companies are buying up doctor practices, urgent care centers, minute clinics, surgery centers, and pharmacies. This is centralizing all the profit under an organization notorious for screwing over medical providers and patients alike. And there's a real risk of insurance companies steering their customers towards centers owned by that insurance company without transparency. Hospitals are corrupt enough, but imagine receiving care at one owned by United Health. Next story. A whole lot of unnecessary suffering that families bring upon their supposed loved ones. Imagine how horrified you'd be if your friend told you they are putting their elder dog Luna on a ventilator because after her aging, achy hips failed her and they did the hip replacement, Luna got pneumonia. Of course, she can't eat anymore, so they will put a feeding tube in her and feed her. Then they will have people clean her up when she craps on herself. But at least they don't have to worry that she will pee on herself because after the pneumonia, her kidneys failed, and now she's on dialysis. They visit her a couple times each week because they love her. No, that's considered inhumane to do to a dog. We do it to millions of elderly humans, though. Next story. Imagine being stuck in a windowless white environment with bright fluorescent lights, beeping machines, pained moaning, and poop smells for 12 hours. Now do it with less staff than what's required to manage the volume of people. Now throw in 3 years of burnout from the pandemic. Now, consider how grumpy and frustrated you would be, and consider what would make you stay in said job. Next story. Nurse-to-patient ratios are now dangerously unsafe. If your nurse has 5+ patients, the odds of you dying are like 60% or more. Hospitals can't hire enough nurses and all of the good ones left due to low wages. Also, your nurse may have an inappropriate nursing assignment. This means the patients are really sick and that nurse shouldn't have all of those patients. This also means some patients who are really sick, think on life support in the ICU with multiple devices to keep them artificially alive, are not that nurse's only patient when they should be. This also increases the risk of patient harm. Also, a brand new nurse may be given a challenging patient assignment that is extremely inappropriate to them. Due to staffing shortages, this is the only option for the nurse in charge. Many experienced nurses are burnt out and left the bedside, so this has left a lot of inexperienced nurses to be in charge of a unit or taking care of extremely sick patients that they really shouldn't be. CEOs, CFOs, or anyone else in the C-suite typically don't care about patient outcomes, only the hospital's bottom dollar. The number of assaults on nurses is really high, and nurses are pressured by management to not press charges. If you don't have an advance directive or living will, or don't know what that is, you should look into one ASAP. CPR is brutal and many times do not have good outcomes. Many people do not have a good quality of life after these events. I would not want my loved ones to go through CPR. Don't distract the nurse or talk about irrelevant things when they're scanning, hanging, and administering medications. This is a very critical time that the nurse needs to be focused on administering medications. There are certain checks the nurses are required to do. This is the last stop for the nurse to be sure they have the right patient, the right drug, right dose, right route, right frequency, and verifying they're not giving you a drug that you're allergic to. Just because you see the nurse sitting at the desk doesn't mean they're not busy. They're likely documenting care they've provided, checking physician orders and documentation, and looking at their schedule, etc. Nurses very often don't get 30-minute lunch breaks, or even 15-minute breaks, or bathroom breaks, or water breaks. There have been many 12 to 14-hour shifts I have worked in the ICU where I went to the bathroom one time and didn't drink any water. Oh, and I inhaled my cold lunch in under 5 minutes, if I was afforded that opportunity. If you see a nurse or hospital staff member running, now is not the time to ask them for water, a snack, a blanket, etc. They are likely handling an emergency. If you are in the ER and someone is actively dying, think needing CPR, needing immediate life support, actively having a heart attack, a stroke, suffering from a life-threatening emergency, etc. I don't care how long you've been waiting, they will be seen before you even if they have been in that ER for 1 minute. The ER is not the place to get an STD test. Next story. When the nurses are sitting at the computer, doing nothing, they're documenting. In healthcare, if it wasn't documented, it didn't happen. That means every single patient interaction needs to be documented, as well as their interaction with the doctors, the pharmacy, etc. They are expected to be a walking transcript of every medical interaction. On top of delivering meds, catching and reporting doctors' mistakes, communicating patients' preferences to doctors, dietary aids, performing life-saving interventions, and arranging pillows, just so, on top of expected to work mandatory overtime, we're talking 16-hour shifts for however long. If you see one laughing, or eating, or sitting, it doesn't mean they don't care. They're just not robots. So, vote for safe patient ratios and everything that comes with educational encouragement to staff our failing healthcare system. ETA. Everything is documented, from the regularity of your bowel movements, the respirations, the amount of time you breathe in a minute, to the color of your urine, your range of motion, if you're developing a red area, a rash, anything and everything could be a clue to either a patient's deteriorating health or improvement of health. Multiply that by 3 to 7 patients depending on what type of unit you're on, general medical floors versus ICU, and that's why your nurse is at the computer all the time. And if you're surviving, doesn't give a dang if you're hungry or cold, there's not enough people for that. At least one of her patients is about to go from bad to worse any minute now. Next story. We actually really care about you. You aren't a number to us, and when you have an unexpected outcome, we grieve. We have to support each other, and we have care conferences to process our feelings. Sometimes we even need time off work to emotionally recover. I never knew how much doctors and nurses really cared until I became one. Next story. As a hospital social worker, a lot of people think home care is going to include an insurance-covered home health aide. There is no such thing. You have to private hire or get sent to a nursing home for rehab. The staff gossip about all the patients' families. It is easy to get labeled as needy or difficult. Bringing in food for the staff goes a long way. Next story. Most states in the U.S. do not have legal limits on the number of patients a nurse can be assigned to watch. California has long been the only one who has a legal limit on the number of patients an RN can be assigned. Also, with the expectation that they have fewer patients to watch if the people they are taking care of are acutely ill. There are a couple of states in various stages of possibly passing legal limits, but in the majority of states, staffing is arbitrary and completely at the whim of the hospital. They deliberately understaff, hide the information, and then blame the nurse when things inevitably go wrong. Who pays the price? You do. In death, infections, bed sores, medication errors when things get rushed, injuries like falls when people try to go to the bathroom unassisted because nursing staff can't physically be multiple places at once. The list goes on. There are a lot of safety-related things nurses are responsible for behind the scenes that are almost impossible for them to get done because of the expectations. It's dangerous. Take a look at r/nursing and read some of the stories there. You will be appalled. There have been studies proving that for every extra patient a nurse gets assigned above a caseload of 4, the risk of death for the patient rises by 7%. It is not at all unusual for nurses across the country to have 8 or 9 or more patients with varying levels of severity of illness, and in some settings, even more than that. I personally know of someone who worked at a facility in the southern U.S. where it was routinely staffed to have 1 nurse and 1 assistant for 20 patients on a night shift psych unit. And no, contrary to popular belief, patients do not sleep all night. The public should be furious that there is no federal standard set in law, and the level of risk you and your family take on in hospital is down to the luck of your zip code. Next story. I am a bereavement midwife. In the morgue, there are fridges that are specially designed for and only ever contain babies or children under a year old. I've had to transfer babies down there, and I hate it when there is another baby there, but I feel relief that the baby I've transferred isn't alone. I know that sounds weird. Next story. I work in outpatient specialty pharmacy, which means we do a lot of discharge meds and oral chemotherapy. Insurance is the biggest scam and actively makes patient outcomes significantly worse because they delay treatment or put insane limits on the meds they will cover. There are lots of cancer patients who die while waiting on their insurance to cover the medication they need to survive. On the off chance I ever see any health insurance executives, it's on site. They're evil corporations, and I would personally beat the crap out of every single one of them if I got the chance. Next story. Hospital life is dysfunctional. Everyone and everything is worked to the bone for a profit by management and insurance. Doctors, nurses, nurse assistants, respiratory therapists, environmental services, transport, radiology technicians, facilities, and everyone else who are the backbone of the hospital is wrung out just so the higher-ups can get a fat paycheck and bonus for their cost cutting. The last 3 years have shown how disposable administration sees the workforce. Don't get me wrong, a lot of us care and give the best care we can with the supplies we are given, but it's demoralizing when your CEO sells your hospital out and our new overlords don't even feign to care. Next story. Money is the top priority for most hospitals. The majority of hospitals are very unsafe. Some of the adverse events happening to patients are not reported to family. Doctors lie to patients all the time. The majority of healthcare workers educated and trained during COVID have a lot of gaps in their education and their training. The U.S. has some of the worst outcomes in the industrial world. Care was much better 20 years ago, and it will be a very long time before we're able to get back to that. I'm an ICU nurse with 30 plus years of experience. Next story. I am not currently a hospital worker, but for a time I did work in one. A certain hospital in New York City had a dead mice in the basement for God knows how long, one of which had decomposed to the point that all that was left was just a bit of fur, mostly bones, and some orange dust-like powder the color of rust, which my coworker and I guessed to be what was left of the organs. Next story. Note, not a hospital worker, but someone who regularly made deliveries to multiple hospitals. The nurses and doctors have separate break rooms, which might not be surprising, but the staggering difference in quality is shocking. The nurses' break room is dingy, overcrowded, and maybe has some water that they can drink. Meanwhile, the doctor's break room is fully stocked with food and beverages, spacious and meticulously clean. Next story. I'm reading these and am stunned at how much better the hospital I work is than these experiences. Maybe it's because my hospital is a children's hospital, but I see every level from where I sit. And I know from the C-suite down to the cleaning crew, everyone is dedicated to the mission. We are driven to be interprofessional with every patient. So rounds include physicians, fellows, residents, med students, nurses, pharmacists, and therapists. Amazing crap gets done no matter your ability to pay. And 95+% of our patients are Medi-Cal recipients. We are fully staffed, and during the pandemic, we didn't lay off or furlough anyone. We have almost 2 years of cash on hand and have diversified income streams. I had no idea we rocked as much as we do. Next story. Psych hospital, former, we had a no list. We weren't supposed to, it's against the law, but I can tell you 100% every psych hospital had a list ferreted away in the intake office with the names of people who are never allowed to return. If an offender is on the adult unit, all adults must be notified. If a predator is in the child unit, it's considered confidential information and we are forbidden to share that with anyone, including the parents of the children on the ward. What the F? Hot tip, don't send your kids to psych hospitals that are not attached to medical systems. Single-location unaffiliated psych hospitals are likely to be for-profit, and they put money ahead of everything, including your kids. Another hot tip, you don't have to send your kid to whatever hospital the ER tells you that accepted your kid. Reviews of psych hospitals are a crapshoot. The best psych unit in our area is rated 2.5 stars. The place where I worked, which I quit because I had to report them to the state, has 2.7, and is actually the highest rated psych program in the area per Google reviews. If your kid has a therapist, that person for sure knows the bad hospitals and will be only too happy to give you that list. If you're an adult and have a therapist, that therapist knows those hospitals too. No one wants to think about being hospitalized, but if you have to be, you want a solid list in the notes on your phone rather than just going wherever they get sent. Next story. I'm not in the medical field at all, but I had a very awkward experience in the ER one night. I had fallen off a porch the day before and pulled some muscles in my back. The next day, I decided to go to the ER because I was having a hard time standing up and sitting down. The ER was swamped that evening and didn't have any rooms available. They had some hospital beds set up in the hallway and took me to one of those. Not being able to sit or stand upright, I just leaned against it, trying to be out of the way. About 20 feet away was a door to a room. I could hear a lot of commotion, followed by the doctors leaving the room a bit disheveled. About 10 minutes later, a family was escorted into the room. There were a lot of wails and sobbing, and I could overhear a doctor and nurse talking. The guy had been in a really bad motorcycle accident and had died. The commotion I heard was, to my knowledge, him dying and the doctors trying to save him. I'll never forget making eye contact with the mother when she came into the hallway to make a phone call and notify the rest of the family that he was dead. I felt like a piece of crap. I was getting seen because I got drunk and fell over a railing, and her son was dead. Next story. The reason you might be waiting for ages for a bed might be because the hospital can't find a care home to release a patient to. If the patient is violent or difficult, then many care homes will refuse them, which means that not only is that person taking up a bed, but also a staff member that needs to supervise them. And even though the patient is fit to be released, the hospital can't if they don't have a care home to go to. I've seen people take up a bed for weeks and months, and the staff are simply not trained to deal with patients like that long term. Next story. Pillows are recycled. What I mean is, the pillows in hospitals are completely plastic and cannot be laundered. They are intended to be wiped down with disinfectant to clean them and then stay with the patient until they are discharged, when the patient can either take it home or gets thrown away. Unfortunately, for whatever reason or reasons, the pillows get cleaned by housekeeping passing down from patient to patient with a new pillowcase slapped on it, or it's cleaned and placed into a closet until needed. Next story. I'm an ICU nurse, and it absolutely saddens me to write this, but doctors straight up lie in their notes. I have personally spent 30 minutes in face-to-face evaluation of this patient. No, you haven't. I've been here all day, I haven't taken a lunch, and I only peed once, and I somehow haven't seen your butt anywhere near the unit. Saw another note about a patient who was there for concern over limb ischemia. The note said the limb was warm, so collateral circulation must be adequate. I had that patient for 3 days straight, 12 hours a day, and that limb was never warm. Never. It was cold. Collateral circulation was clearly not adequate. Next story. Mental health hospital worker that just quit. Calling over and over will not change how much we will tell you. If the person in our care does not sign a release of information, we literally cannot talk to you. We would love to, so we can know what home looks like, their baseline, meds that have worked, etc., but we just can't. It's infuriating on both sides, and we wish we could make it easier. MH hospitals are massively understaffed and commonly underfunded. Complaints you hear about care may be true. Funding for meals and services are up to the hand of corporate or insurance companies, who never sees your loved ones. We hate it too. Sometimes if someone is too dangerous and is hurting other people and refuses to take medications and no one can take them, we have to just release them to a shelter. I wish we could send them to a prison, but we can't because they are hospitalized. So they have to go to court for due process for any assault charges. We had a client that we were scared he was going to hurt us. Cops wouldn't do anything. Got rejected from every hospital in the state and then released him. He got picked up quickly, and I have no idea where he is in the system, but he was so impulsively dangerous that I don't know what anyone is supposed to do. On that note, if people are not successful when attempting self-unaliving, they may show up into a literal crap show where others are in full-blown psychosis or mania, and it does not make for a therapeutic environment. We are aware. Go straight to the program administrator because anyone on the floor is probably at their wits' end saying, I wanted to help people, but am I? Not like this. Mental health is garbage in the US, not because people don't care. The people who set the system in place and with the money are the ones that don't care. Next story. If visitors knew about nosocomial infections and typical housekeeping practices, they'd never set their purses, tote bags, backpacks, etc. on the floor when visiting patients, and they'd wear shoe covers to burn their shoes when they get home. About 20 years ago, my grandmother was hospitalized for a bowel biopsy to check a tumor. Due to the nature of the bowel being a pretty filthy place, the biopsy is treated like any intestinal surgery. Bowel prep included a very potent laxative that liquefies the contents very quickly. The nurse warned grandmother to stay seated on the portable toilet in the room or on the fixed toilet in the bathroom, but there were several family members visiting and grandmother was too embarrassed to be seen sitting on the toilet with visitors around. I tried to warn my family that we should leave, give the nurse and aide room to work, but nobody was listening. I moved to the far side of the room near the door and waited. As expected, while she was standing and chatting with family, poor grandmother's bowels emptied like a plug had been pulled. Startled family grabbed purses, tote bags, and backpacks and scampered in every direction as the pool of liquefied feces spread from wall to corner to corner. A housekeeper came in with a broom and scoop, followed by a string mop, and filled up the rolling bucket. Curious, I waited nearby and watched. After cleanup, the housekeeper rinsed the broom, mop, and bucket in the utility room and set them aside to use on the rest of the ward. No effort at real hazmat cleanup. Not unexpectedly, grandmother never fully recovered. She died just short of her 90th birthday from complications related to an infection that never fully healed, and her mind was zapped by the anesthesia and morphine. Some folks suffer long-term dementia after anesthesia and opiates for pain. She had been sharp as a tack before surgical complications, and it was hard to watch her rapid decline. Technically, she died from congestive heart failure, but that was the end result of a few months of a losing battle with a lingering infection. It might have happened anyway, but the lax hygienic practices and wound care didn't help. Turned out the tumor was benign, but as of that era, there was no other practical way to biopsy a bowel tumor without invasive surgery and accompanying complications. Every time I'm at the grocery store and see someone setting their tote bags and purses on the checkout conveyor, I wonder where those bags have been. I'll always prefer plastic bags for food sales. Many bags nowadays are made to break down fairly quickly under exposure to sunlight or normal bacteria on the ground. Background: I worked in nursing for years in the 1970s and 80s, including OR and dialysis, and was a caregiver for 2 grandparents and my mom, so they were able to live at home for as long as they wanted. Next story. The long waits are not from personal incompetency or laziness. Most healthcare workers do not stop working or moving. The workloads are high. There are many patients that we are taking care of simultaneously. There are multidisciplinary services that we are sometimes waiting for or are involved, and it takes time. We have to wait for medicine to be administered and labs to be drawn and results to be brought forward and imaging to be read. And after all that, we get to spend 20% of the time with you, and the other 80% is done doing the paperwork or writing the note. Please understand that it can be difficult because we have our lives as well, individually going with the same considerations of personal challenges that affects human beings. And in lines of work that you are in service of others, we can feel emotionally exhausted and our resources depleted. We're sorry if we cannot or did not demonstrate the compassion that you needed in that moment. It's not us, and it is not you. We also need more windows, more nature, and more of a human experience in this place that is meant to take care of your health and get you back to it, not just damage control, not just delaying natural selection under the illusion of saving lives. Thank you for being an active participant in your health. And if you're not, we appreciate you taking notice to this and becoming a part of it. You are more effective than almost anything that we can do for you. Remember the miracle of your body. Remind yourself of the miracle of your mind, your heart, and your ability to heal, strengthen, and thrive. Thanks for considering this. Next story. They will push a life-saving $260,000 surgery that you later found out could have been prevented with a simple increase of one of the patient's current meds. So educate yourself. Get second opinions. Medical mistakes happen often, and oftentimes they'll never tell you. Risk management, patient relations, is not on your side once a mistake was made. They are looking out for themselves. Sepsis is a leading killer in hospitals. Hospital-acquired infections are common, especially in the ICU. Greed stemming from the top is killing decent healthcare. Next story. Started working as a PA hospitalist about 9 months ago. I find that every couple weeks we get at least one repeat patient who is a professional hospital goer/malingerer. They may be between jobs or homes, or they may just be addicted to pain meds. Anyway, they know exactly what to say to get admitted, and they always have chronic health problems that are bad enough that we have to take their complaints seriously. Chest pain is a common one. Then once they're in, they treat the nurses like their own personal waitstaff and throw hissy fits if they don't get their food, or the TV isn't working, or if their pain meds are more than 10 seconds late. When it comes time to discharge them, they'll call patient representatives and appeal their discharge for as long as possible. Then, when they're discharged, they find a new reason to come right back. Rinse and repeat. Next story. I've seen both living and dead roaches inside of OR suites, albeit not while they're actively in use or even on anything other than the floor, but that's something to think about. Also, I've seen way too much genitalia than I would ever hope to see as someone who works in the pharmacy. A lot of surgeries have your open and out nether bits facing the window or the door for any tech, nurse, custodian that has OR clearance to even see when they're not on your care team. ETA, I work in the best hospital, in terms of ratings and patient outcome, in my suburb. We are also the only Level 1 trauma ER and Level 4 designation LD/NICU in an extremely large area, so we get cases from out of state and sometimes out of country. Next story. There are other staff members out there who are just as affected by the loss of a patient than the doctors and nurses. I was a service worker/porter in an operating room for 15 years and picking up patients who are fine before surgery and animately talking and coherent, then to die in surgery or be let go because there's nothing to be done. Inoperable abdominal aortic aneurysm, that one hits hard. Having to take them to the morgue afterward hits differently. I think I was traumatized after a young pregnant woman was brought in to remove her fetal demise. She had been beaten so badly that the baby had died. It was an emergency surgery late at night, so the surgery was done in the main operating room. Anyways, I clearly remember fixing her hair under the cap because it was in her eyes. The tape holding her oxygen tubing in place had hair stuck to it, and me being never okay with hair in my face, I fixed it. Neurotypey. She looked into my eyes and whispered, "Thank you." And then she died in surgery. I'll never forget her family cries. We took her and the baby into an area where they could see them afterward. The baby was so beautiful. Full term. Her poor fiance lost his wife and baby at once. I thought I was okay afterward, but the next time I drank it all, it hit me. I had to leave a wedding I was at because I was an inconsolable mess. Oh man, there are so many stories. There are so many that hit hard. I definitely learned compassion in my job, but having to shut down emotions until the job is done is a necessary coping mechanism. It's not that we are heartless. Next story. CNA here. The whole process of your pain meds doesn't take forever because of us. It's literally because although the doctor puts in the orders for the medicine, pharmacy has to do a lot of crap. They have to verify the order by literally calling that same doctor and double checking the order was already added into the computer to be accepted. Then we have to wait for them to fill it and send it up. Yes, we understand you are in pain, and we're worried that you're not going to get your first dose of important medicine, but imagine all of that, and then having to do that for like 200 to 500 people. Maybe more depending on your hospital. Half the time, there's only like 3 to 4 pharmacists on duty for the whole building, so bear with your nurses, doctors, and pharmacists because they're trying. Next story. How the pharmacy team quietly keeps everything running. Every patient-specific medication, floor stock in your Omnicell, and even the anesthesia stations are all stocked by the pharmacy staff. We work really hard to ensure that meds are stored safely and correctly, that cycle counts are updated, and that expired meds get removed. Not to mention all the IV compounding, and that's just the technical side. Pharmacists do a whole lot more with verifying orders, answering all sorts of drug information questions, and clinical pharmacists round on patients. Next story. When our baby passed at 2.5 months, a beautiful angel of a nurse finally talked me into giving her over. She very gently took her wrapped in her favorite blanket with her favorite bunny, and she walked away. It was the hardest moment of my life, but that nurse made it safe to give her my baby. I can honestly say that in the 42 years since it happened, I've never once wondered how she got from the hospital to the funeral home. Now I wonder, I hope, they were as gentle and caring as the nurse. She was a tiny baby, and you just have to hope the people dealing with her remember she is someone's child, and you have no choice in handing her over to the professionals when you just want to take her home. Next story. I work in a hospital supply chain. I am a responsible part of a team that is responsible for helping hospitals buy products and services at a better price or have better patient care and outcomes. It's very rewarding to me. You would be amazed at how much struggle hospitals experience from a supply standpoint. In no attempt to hit the panic button, hospitals are constantly bombarded by bad products, recalls, shipping delays, manufacturer defects, the list goes on. These are products like syringes, wipes, bandages, pumps, and catheters that you are being treated with. The response from hospitals is finding a substitution so that they can continue to provide care. Seeing how it all barely comes together scares me a bit. I really don't want to be in a hospital. Next story. CT technologist here. Please, if you or a loved one have any reason to believe you are experiencing a stroke, do not wait to come into an emergency department. Positive interventional outcomes are inversely correlated with time passed since embolization. We, the hospital staff, see a lot of stroke victims who we simply cannot treat because too much time has passed. It's really sad to see. Next story. I deliver blood to hospitals. Most people don't realize the blood supply in the US is at critical levels. There have been a couple nights recently where a hospital calls for more blood of certain types and I've had to tell them we can't fill the order. We just don't have the product. It's the holiday season and people don't have the extra time to donate. I work in a rural area where the next hospital might be an hour or more away. Think about that before trying something risky. Even if you are a trauma patient, there might not be enough blood at the hospital to keep you alive. Next story. That PCAs and CNAs do a lot more than just wiping butts. Most of the time, we're the ones who your loved ones see every day because no one comes to see them. The workload is also strenuous, and we do our best to help out both our patients as well as nurses with everything they need, but we're paid a little to nothing. But everyone in healthcare, who aren't doctors, administrators, managers, or the CEOs, deserve better pay, a safer environment, as well as safer ratios. Most of the time, we're given a high patient-to-staff ratio and then get yelled at by management and family members because we couldn't do XYZ in the time that they wanted us to do it. Also, the amount of times I've been assaulted or threatened by patients, reported it, and nothing was done. This happened to many of us, nurses, transporters, lab, etc., and the hospital doesn't blink an eye. But they'll have signs up saying they don't tolerate any of that behavior from patients or their visitors. Next story. Now I've got a few. If someone is dying, we know. Refusing to put them on painkillers or an IPOC isn't going to save them. Instead, you are just prolonging suffering and causing them to die in pain. During visiting times, yes, we do tend to sit around on the computers. I have had many family members shout saying, "We aren't doing anything." That's because 1, we've already done everything earlier. 2, we aren't supposed to do any treatment or personal care during visiting times unless necessary. We don't want visitors to have to smell open wounds when we're changing dressings or changing pads. We do all that stuff when there isn't any visitors on the ward. And 3, we are filling out all the essential documentation that we have to do, as visiting times are the best times to do this, as the patients are having some time with their families. So please don't think we are sitting around being lazy. We're not. The nicer you are to us, the more we are going to try and take time to give you extra care. If you shout and abuse us, you're going to get the bare minimum. Please just be nice to us. We don't get paid enough to be treated like crap.